Hello, my name is Suzanne, and we're going to cover blood pressure. Blood pressure is very easy to understand, and it's very easy to manipulate. So as an adult, I'm probably 60 or 65% fluid. Infants are 80% fluid. So a human is kind of like a piece of fruit. To me, we're kind of like a watermelon. We look like a whole thing, but we're mostly fluid. Or like a grape. You want to be a grape. You don't want to be a raisin, you want to be a grape. So we're mostly fluid. So I think of blood pressure strictly as fluid. Niagara Falls has a lot of fluid, it has a lot of pressure. My kitchen sink does not have a lot of fluid or a lot of pressure, but the problem with the sink is the faucet. The hole's too small. If I had a bigger hole, a larger gauge IV, I could automatically pump more fluid through it and get more pressure over here. My whole goal is to get pressure over here. With the kitchen sink, I just need a bigger hole, a larger gauge IV, and I can automatically accomplish that. If I had a little creek and I put a ton of fluid into it, it would turn into a raging river. And that's exactly how you and I work when it's related to blood pressure. You and I are mostly fluid. So when your patients have low blood pressure, you should expect to start giving them IV fluid. Human beings are very easy to dehydrate. 50% of the in-hospital cardiac arrests that you attend, 50% will be caused by two things that begin with the letter H, hypovolemia and hypoxia. In this video, we're just going to cover blood pressure and hypovolemia. So in blood pressure, there's a top number and a bottom number, a systolic and a diastolic, a squeeze and a rest. All humans, infants, children, adults, should have a blood pressure, say, of 100/60. And what I mean is the diastolic is 2/3 of the top. 120/80. The diastolic's in its right spot, it's 2/3 of the top. None of your patients should have a blood pressure, say, 100/30. Your 100's okay, but your 30's not. If you see 100/30, that's an early sign of septic shock. If you see 200/100, oh, that's too far away as well. But what they're showing you is ICP, increased intracranial pressure in their brain. So if you see 100/30, they'll probably end up in a medical ICU. And if you see 200/100, they'll probably end up in a neuro ICU, just so you know. They're trying to warn you with the diastolic. If the numbers are too close, like 60/40, well over 90% of the time it's going to be hypovolemia, and even less than that, a fraction of the time it's going to be obstructive shock. Obstructive shock is exactly what it sounds like. Something's blocking blood flow. So that would either be a massive pulmonary emboli, a big clot right here, a tension pneumothorax, or a cardiac tamponade. And those three things are extremely rare. So if you see 60/40, well over 90% of the time it's going to be hypovolemia. And you should expect to start giving them IV fluid. Every form of shock is going to get IV fluid, even cardiogenic shock. So I think of blood pressure as fluid. You're going to have someone with low blood pressure, we're automatically going to start giving them IV fluid and turn them into Niagara Falls. There's only two types of IV fluid you're going to bring to rapid responses or codes. You would use LR or lactators ringers under very limited circumstances. You're going to use LR if you work in the operating room, if your patient's pregnant, if your patient suffered severe burns, and now septic shock in the ER as long as your kidneys can handle the potassium in LR. LR is a better flavor, it's a better formula, and you're going to see more LR soon. Now that being said, if you work on medicine, you don't have LR, Boston EMS doesn't carry LR, so lactators ringers or LR to me is like Gatorade. The pH is pretty close to you and I, 6.5. Oh, that's a good pH. And it has two critical electrolytes in it for our heart, potassium and calcium. You're going to hear me talk about calcium in about 3 minutes and link it completely to raising blood pressure. So I think of it as like Gatorade. The pH is very similar to ours and has two critical electrolytes in it for our heart, potassium and calcium. If that is not the case, you're going to use 0.9 normal saline. Now there's a big difference between these two, and someone told me that LR is actually $1.75 more a bag, and that actually plays a role. Can you imagine? I know. Amazing, eh? So if your patient is not pregnant, didn't suffer severe burns, you don't work in the operating room, or your patient doesn't have septic shock with working kidneys in the ER, you're going to use 0.9 normal saline. Now, normal saline has no electrolytes, but it's very acidic, 5.6. If I give this patient 3 boluses of LR, I'm not going to adjust the pH very much, and I in essence gave him potassium and calcium. Except we don't use a lot of LR. We use a lot of normal saline. So if I give this patient 3 boluses of normal saline instead, there's no electrolytes, but I'll put them into metabolic acidosis. So the consequence of all the normal saline is metabolic acidosis. You might actually have to give sodium bicarb to reverse it. I don't really care which IV fluid they pick. I love IV fluid. I love IV fluid and oxygen. Honestly, there's not enough of it for me, honestly, on earth. If septic shock, an adult with septic shock hits your emergency room, you're going to give 6 or 8 liters down there. When they get up to somebody's MICU, they're going to give another 8 or 10 liters of IV fluid. If you've ever been in the medical ICU, the patients look like the Michelin Man. They're all puffed out with fluid, and it's still not enough. So if that patient needs that much fluid to support their blood pressure and stay alive, they're most likely going to go into congestive heart failure. And so we'll intubate them in about 10 or 15 seconds. So realize I'm not the one being intubated, but intubation is not a big deal. It's awesome if it's temporary. It would be more problematic if we didn't support their blood pressure. Now, let's go back to blood pressure. So if your patients have low blood pressure, expect to start giving them IV fluid, one of those 2 types. So pretend my patient has low blood pressure. With an adult, the definition of low blood pressure is a systolic blood pressure less than 90 millimeters of mercury. If you have an adult with a systolic less than 90 millimeters of mercury, we label the adult unstable. We're very polite in the adult world. We'll say they're unstable. Whereas in pediatrics, we would just say they're in shock. So it's much more direct and to the point, but it's the same thing. If someone ever says to you, my patient's very unstable, they're referring to the blood pressure of 73/37. So just expect to start giving them IV fluid. And if you put them into congestive heart failure, just realize they'll be intubated. So they're gonna need that IV fluid to support their organs. In the ICU, we don't talk about systolic and diastolic blood pressures all day because we have to talk about it literally all day long. We talk about this other number, the mean arterial pressure. So the MAP, or the mean arterial pressure, is you take the systolic and diastolic, and it's this calculation of these 2 numbers. The MAP is a calculation of the top number and the bottom number. The MAP is a consistent blood pressure. The MAP, or the mean arterial pressure, must be at least 60 for the kidneys to be fed. So they want the MAP 65 and higher. So really all you're doing is taking a calculation of these 2 numbers. And honestly, some days, especially in cardiac areas, it's very hard to keep their MAP 65 and higher. 60 you can get away without drips, but when they wanted 65, you're gonna probably need drips. So every 1 minute that this patient sustains a MAP of 50 or less causes gross organ damage. So realize blood pressure is very easy for you to manipulate and it's easy to understand. We're mostly fluid, so if the blood pressure is low, expect to start giving them IV fluid. Patients in certain areas in the hospital like CCU, open heart surgery, thoracics, they're not going to give those patients IV fluid to control the fear of them going into congestive heart failure. So they're going to keep those patients deliberately dry. So just realize we have a plan of care for them as well. Now, since you're mostly fluid, I'll turn you into a Windex bottle. Okay, now you get to be a Windex bottle. Okay, your Windex bottle's full. So the patient is not hypovolemic, but I'm giving the Windex bottle a wimpy squeeze. If you want me to get more pressure out of this Windex bottle and it's full, I should give it a really good squeeze. When I give it a really good squeeze, that's called a positive inotrope. But if the Windex bottle's empty, I can improve my squeeze and there still would be no increase in pressure on this half. Does that make sense? So basically, when you give them a positive inotrope like calcium and increase the squeeze, you're automatically going to raise the blood pressure. But if they're hypovolemic and there's not enough fluid, squeezing it better won't improve the blood pressure. How you know if they're hypovolemic or have too much fluid on board are by checking serum osmo levels. Serum osmo is particulate. So pretend I have too much fluid on board. I drank a bathtub full of fluid. My serum osmo will be driven very low. And then I'm dehydrated. I spent 3 days in the desert without a drink. My serum osmos would be very high. So if I'm dehydrated, it'll drive my serum osmos up, and if I have too much fluid, it'll drive them down. If your patient's serum osmos are within normal ranges and all you do is give them a positive inotrope, you'll automatically raise the blood pressure. Calcium is a positive inotrope. So when I was a baby nurse, we never replaced magnesium. Never. And I did open heart for years. And I'd say to the docs and the PAs, what about the mag? Don't worry about it. Not a big deal. Just keep an eye on the potassium. Nothing on the mag? No, don't worry about it. That went on for years. And then one day I woke up and magnesium became super important. In clinical settings, you'll see we replace the potassium magnesium constantly, the K and mag, the K and mag, the K and mag. Magnesium and calcium have an opposite or counter effect in our body. If you take a bunch of magnesium, it'll drive your calcium down. If you take a bunch of calcium, it'll drive your mag down. Our patients take enormous amounts of magnesium, and so their calciums are always very low, which is helpful for people like me. So I get upstairs one time, and I got called to low blood pressure all the time. You have no idea. So I get upstairs one time, and it was the only time in 20 years I ever asked, what have you already done? And they had already given this lady 2 liters of fluid. Now, I thought it was a great idea. After a liter of IV fluid, your adult will not be in hypovolemia. If the first fluid bolus raises and stabilizes their blood pressure, they were hypovolemic. If the second fluid bolus raises and stabilizes their blood pressure, they were hypovolemic. If the second fluid bolus you give this person doesn't raise and stabilize their pressure, it's not hypovolemia. It's something very significant. The person in front of you is either septic or hemorrhaging. Call a rapid response. The rapid response team is going to hang the 3rd fluid bolus. After 3 fluid boluses, just realize you'll put patients into a coagulopathy state. So here comes more fluid, blood products, red blood cells, platelets, FFP, and drips, all more fluid. So making blood pressure go up is easy. You're going to use IV fluid, and after 3 boluses, you'll put them into a coagulopathy state. So here comes blood products, red blood cells, platelets, FFP, and drips. But making blood pressure go up is easy. For your patients in CCU thoracics that they're not going to want to put into these situations of congestive heart failure, if their serum osmos are within normal ranges and all you do is give them calcium, you'll immediately increase their blood pressure. But squeezing an empty Windex bottle won't improve your pressure. So if you work in those areas, look at serum osmos, their calciums will be low unless they're deliberately replacing calcium levels. Magnesium is going to drive their calcium levels down. Calcium is going to increase the squeeze and raise your blood pressure. Link calcium in your mind to blood pressure, because that's how it works in our body. Calcium reverses calcium channel blockers. So making blood pressure go up is easy. If you have a patient and their serum osmos are within normal ranges, you can use calcium gluconate. That's what most people are going to use, calcium gluconate. Calcium gluconate is an IV piggyback. The only people that really use calcium chloride work in anesthesia. So realize, if you work in CCU or open heart or thoracics and the patient's blood pressures are low, check their serum osmo levels. If they're within normal ranges, if their calcium levels are low, replace it with calcium gluconate and you make the blood pressure go up. Making blood pressure go up is easy, and it scared me for years. So realize making blood pressure come down is the easiest thing on earth. Any type of medicine would drop someone's blood pressure. Sublingual nitro under their tongue, a paste or patch on their chest, PO medicine by mouth, IV, IO, IM. If you had a patient with high blood pressure, hypertensive crisis, and you called me, all I would say is, always got high blood pressure? How quickly do you want me to drop it, and where do you want it to land? Making someone's blood pressure come down is a breeze. If I had a raging river and I took some fluid out, gave them a diuretic, it would automatically go back to a little wimpy stream or creek with less power and pressure. So just realize, once you understand how blood pressure works and how to manipulate it, it's easy. But if your patient has a blood pressure, just realize you're in a rapid response, you're not in a code. In codes, patients have no blood pressure. So realize manipulating blood pressure is easy and fairly reliable. Once I figured out how it worked, the serum osmos, calcium, IV fluid, it never gave me any grief. Okay? I hope that helps. You guys, keep saving them for me. Thank you.